thank you very much for being here this morning, and I also want to extend my thanks to the organizers for inviting me to this very exciting conference. I'm delighted to be here and to be part of a process to help bring brain injury rehab to Greece. I am, as you can see, the Howard A. Rusk Professor of Rehab Medicine. And Howard Rusk, who was the father of rehab medicine, made it his goal to bring rehabilitation throughout the world. So now that I hold that seat, I feel obligated to be here, but also honored. So thank you, and congratulations on just arranging a terrific conference. I've also had the honor of working with Dr. Ben Yashay for the past 18 or 19 months. So I'm just delighted to be here. What I hope to do today in this opening presentation is to give a broad overview of traumatic brain injury from a point of view of epidemiology, a little bit about pathophysiology, although you'll be getting an excellent talk later today about pathophysiology, and then talk a little bit about some of the assessment tools we use in traumatic brain injury, and then go on to a brief overall discussion on some of the medical problems that I see as a physiatrist in treating folks with traumatic brain injury. I'll be doing more of that at the workshops this afternoon, so I look forward to seeing some of you there as well. Okay, so everything you wanted to know about traumatic brain injury in 75 minutes or less. Actually, it's a bit of a joke since this is a 3-day conference, and even in 3 days, you'll not need to. You won't get everything that you'll need to know, but it's a start. All right, so first of all, the epidemiology of traumatic brain injury. Who is it that is impacted? Well, I'm going to provide you some data that we have from the United States. I actually tried to get some data from Greece, although it was hard to come by. But I will say in the United States, traumatic brain injury is a much more common problem than people actually realize. Many folks with traumatic brain injury don't have much in the way of physical problems. Many do for sure, but they have cognitive problems with their thinking or their behavior. We refer to these people as the walking wounded. They appear to be okay, but in fact they're not. They can't fulfill their roles as parents or as workers, as teachers and what have you. So we call them the walking wounded. We, in the United States, we estimate that about 95 out of every 100,000 people sustain a traumatic brain injury, most of which are mild. And when we talk about mild traumatic brain injury, I don't want you to get the sense that it necessarily always means not having an impact on their lives. There are many people who have had concussions or repeated concussions who, in fact, the results have had a very severe impact on their ability to function. There are about 1 million visits to the emergency room every year in the United States for folks who've had a traumatic brain injury, and a very, very conservative estimate of the number of folks who have sustained a traumatic brain injury just in the United States is 1.5 million. Now, I can tell you that folks in my field will say that that is grossly underestimated. When you take a look at all of the concussions that occur in sports and falls, the fact that many people who have traumatic brain injury never make it to their healthcare providers. They may not even mention that they've had a traumatic brain injury. The fact that many healthcare workers don't recognize the consequences of traumatic brain injury, the impaired cognition, the behavior problems, and oftentimes folks are misdiagnosed as simply being psychiatric or malingerers or what have you. So I will tell you that this is grossly underestimated. In fact, probably the number of sports or recreational concussions, which are traumatic brain injuries in the United States, account for well over 3 million. So this estimate of 1.5 million is grossly underestimated. Despite that, we estimate, or the Center for Disease Control in the United States estimates that there are more than 3 million people in the United States alone who are walking around with a chronic TBI-related problem. By that we mean something that's lasted longer than 6 months, problems with motor, cognitive function, or behavioral. And despite whatever advances we've made, there are still many deaths associated with traumatic brain injury every year. But if we look at that number of 1.5 million occurrences of new traumatic brain injury every year, that's still greater, even though it's underestimated, it's still greater than the incidence of breast cancer, HIV/AIDS, multiple sclerosis, and spinal cord injury combined. This is how common traumatic brain injury is in the United States, yet it's not really recognized. Now, unfortunately, traumatic brain injury is gaining a considerable amount of recognition, largely because of the unfortunate wars in Iraq and Afghanistan, where traumatic brain injury has become, unfortunately, the signature injury of these conflicts. So the military, the Department of Defense are now recognizing that this is a problem. It's also beginning to be realized because many sports figures, and sports in America is a big thing, and as we'll see a little bit later on, with concussions now occurring on a regular basis in some of our professional sports players, it's becoming better recognized. It's important to know who gets injured. Unfortunately, most folks are young adults, teenagers, folks in their 20s. So oftentimes these people with severe traumatic brain injury often have lifelong disability and can't get back to work. There is a second peak incidence of folks over the age of 75, and these occur largely because of falls. And it's important because as our population ages, we're going to see more and more folks sustaining traumatic brain injury because they're older and they're falling. We're also going to see a lot of younger people who survive into old age. So this is actually going to be a big problem. It's also important to realize that older folks who have the same injury severity as somebody who is younger will not do as well. They have a higher mortality and greater disability. Men are far more likely to sustain a traumatic brain injury than women at a ratio of 2 to 3 to 1, largely because men tend to be more risk takers, and maybe they drive a little faster and what have you. That distribution equals out in the elderly, but I think this just goes to show, at least what my female colleagues say, that men are from Mars, women are from Venus. There you go. A little bad joke there, but you have to try. Okay. Cause of injury. There we go. Traffic-related accidents or traffic-related events, I should say, are the most common cause of severe traumatic brain injury in the United States. In what data I did get from Greece, it turns out that traffic-related accidents are the most common cause in this country. Certainly, it's the cause, the largest cause in many of the developing countries where cars are still a bit of a novelty. I just visited India not too long ago, where traffic-related accidents are extremely common. The assaults, another common cause of traumatic brain injury, much more common in urban areas, although our now thrice elected mayor of New York City, Michael Bloomberg, wants me to assure everybody here in Greece that New York City is the safest, largest city in the United States. So please feel free to come to New York. You won't get beaten up, I assure you. Falls, as it turns out, now has surpassed traffic-related accidents as the most common cause of TBI in the United States, and this comes from data from the Center for Disease Control and Prevention. And as I mentioned, recreational and sports-related activities are being recognized as a source of traumatic brain injury. We have a great deal of boxing in the United States, and boxing is an interesting sport where the whole idea is to give the other guy or million-dollar baby girl a concussion. But it's also with soccer, which you folks all know as football, American-style football. As a matter of fact, some recent data has just been published that NFL players, National Football League players, professional football players are more likely to develop early dementia, potentially because of concussion. It's very preliminary data, but these are the things that are now raising the awareness of traumatic brain injury in the country, and I think it's good that awareness is now increasing. So let's talk a little bit about pathophysiology of traumatic brain injury. And I have here on this slide a number of different CAT scans, CT scans, just to show the wide diversity of how traumatic brain injury can look. I can tell you that if we have an arrow here, there we go. We have contusions, we have subarachnoid hemorrhages, we have severe swelling, we have large extraaxial collections and uncal herniations. We even have scans that look surprisingly normal. I can tell you that all of these could be the scans of someone with a severe traumatic brain injury, yet it looks very, very different, and as we'll see why. And also the lecture later on this morning will explain this a little bit further. We like to look at pathophysiology, traumatic brain injury in a number of broad ways. We like to look at it with regards to injury to the brain that occurs in focal areas, as well as injury to the brain that occurs in wider areas. So we have focal injuries that include contusions, lacerations, localized areas of hemorrhages or ischemia, and diffuse injury that affects the whole brain, and we'll talk a little bit about diffuse axonal injury, which is also known as traumatic axonal injury, and some of the other mechanisms by which the brain can be injured in a very diffuse way. We also like to look at traumatic brain injury with regards to when the pathology actually occurs. So you have injury to the brain as soon as the event occurs. You're in a car and you're traveling 120 kilometers an hour and you're on a head-on collision, and your head gets injured, your brain gets injured. There's nothing you can do about that. It's happened. The only thing you can try to do is to prevent it from happening through legislation. So mandatory seatbelt laws or airbag laws, we certainly have them in the United States. Mandatory helmet laws when folks are riding motorcycles or bicycles. I'm not sure what the laws are here in Greece, although I did see a passenger on a motorcycle without a helmet. I suppose he figures he's in the back seat of the motorcycle so he won't get injured. I never quite figured that one out. But what's important, and this is very important for healthcare providers, is the secondary injury. This is injury that occurs to the brain at some point after the event. And this is something that we can do something about, particularly if we follow some guidelines that have been established, and we'll go through some of those in just a little bit. All right, so focal injuries, I'm sure most of you already know this. The brain in its natural state has the consistency of formed gelatin. It's very soft. The inner surface of the skull is actually very rough. And when we're in, let's say, again, a motor vehicle collision, this very soft brain strikes the inner surface of the skull and it gets contused or gets abrased. Almost if I took my arm and foolishly banged it against the wall, I'd have a contusion on my arm. Any area of the brain surface is susceptible to contusion, but in particular, the inferior frontal lobes and the anterior tips of the temporal lobe are what appear to be most susceptible. And you can see that here in the CAT scan, and it doesn't show up quite so well, but thank goodness for arrows. For those of us who are not radiologists, we can actually see the area of contusions in the anterior temporal lobes and the inferior portion of the frontal lobe. Those contusions can be hemorrhagic, which we have here in the frontal lobes. You can see the areas of hemorrhage. The brain can also be injured just by laceration. It always amazes me when I get patients who have actually had stab wounds through the skull. It just amazes me how that happens. But you can also get lacerations to the brain from a depressed skull fracture that pierces the dura. So you can see that as well, focal injury. You can see little hemorrhages down in the deep subcortical areas as the brain basically gets shaken up. Not only do the nerve cells get shaken, but so do the blood cells, so you can, or the blood vessels rather, so you can see small hemorrhages in the deep matter, gray matter of the brain. Obviously, you can get a whole host of extraaxial collections, classic appearance of a large epidural hemorrhage, usually in association with a skull fracture, disruption of the middle meningeal artery, or at times the dural sinuses. Here is a bilateral subdural hemorrhage. This is a subacute. You can see the bright blood here, darker up here on both sides. Classic appearance of a chronic subdural hemorrhage. Much more common in elderly. As the brain shrinks, the bridging veins are more likely to be injured or sheared, resulting in subdurals, which can actually be very slow growing. So there are a lot of folks who are older who have minor trauma to the brain, but actually won't develop symptoms for weeks, sometimes even months later. Here, a classic picture of it's hard to say. I'm not quite sure how well that projects up there, but diffuse subarachnoid hemorrhage. And trauma actually is the leading cause of subarachnoid hemorrhage worldwide. You can also injure the brain in more focal ways through focal ischemia. You have vasospasm following subarachnoid hemorrhage or compression of the posterior cerebral artery that can often occur in times of uncal herniation. But I do want to spend a little time on traumatic axonal injury or diffuse axonal injury, as it's also known. So you can imagine, again, in a motor vehicle traveling 100, 120 kilometers an hour, having a head-on collision, your head gets jerked forward, gets jerked backwards, there's some torque, and what happens is that the brain itself compresses and stretches and torques. And then you can imagine just the axons, the nerve cells, which are all microscopic, very fine, are being stretched and twisted. And as a result, it causes very widespread injury throughout the brain. And I like to think of the brain as a very complex biological computer network. And as those nerve cells are being stretched and injured, that network stops working properly, it becomes inefficient. I think that's why we have such trouble with cognition and behavior management after TBI. So as I said, it occurs usually as a result of an acceleration-deacceleration event. It affects white matter throughout the brain, the corpus callosum. It seems to affect primarily areas at the white-gray matter interface, as well as the brainstem. And ultimately what happens is as these axons are stretched, depending on the severity of that stretch, they can actually break in two, or what we call axopathy, and it results in something that we see here in this slide over on the right of axon retraction balls. This is what we'll see during a histological examination. And we know that this occurs in severe traumatic brain injury, but it also occurs in concussion, which I don't think people realize. There have been a number of reports where folks who have had mild traumatic brain injury, but have gone on to die of some other cause, and at autopsy, they see these axon retraction balls. So we know that there is injury to the brain, even in mild TBI, that can be permanent, structural damage. It just happens to be microscopic. And we used to think that traumatic axonal injury occurred at the time of the injury, that it was actually a primary event, and certainly the stretching or the shearing of the axon is. But as it turns out, the actual demise of the axons themselves may not occur for several hours to even several days, maybe even a week or so later, because there's a whole host of events that occurs to make that happen. And I'm not going to go into any great detail here, and you certainly don't need to memorize this, although you'll get much more information on this, I suspect, at the pathophysiology lecture later on. But that shearing or that stretching of the axon leads to activation of certain channels, as well as mechanical deformation of some of the pores of the axon. And the killer here is the massive influx of calcium into the cell that sets off a whole host of processes that ultimately leads to cytoskeletal degradation as the structural components of the axons are injured. Axonal transport is impaired, and you get swelling, and ultimately the axon breaks in two, for lack of a better description. The calcium also gets into the mitochondria of the cells. Mitochondria, as I'm sure you all know, the energy-producing organelle of the cells. If that gets injured, energy failure, and now you can no longer maintain the ionic gradient across the cell membrane, causing cell death. That calcium can also set off a process of releasing pro-apoptotic substances that ultimately leads in programmed cell death. So this diffuse injury causes a lot of the trouble that we see in traumatic brain injury. Now, usually after pure diffuse axonal injury, if that's all that occurred in the brain, you'll see a fairly normal appearing CAT scan or standard MRI. And this is really a problem because there are some folks who still believe to this day that if your CAT scan or your MRI is normal, you couldn't possibly have had a traumatic brain injury. But we know that diffuse axonal injury is microscopic. And as it turns out, CT scans and standard MRI scans will only image what you could see with your naked eye if you could peer into the brain. Yet, this diffuse microscopic injury is really what causes much of the problems that we see with cognition and behavior after TBI. Now, you may be lucky, well, lucky, I think that's a relative term here. You may see, I don't have the hour there we go, little petechial hemorrhages within the white matter that is an indication that there has been diffuse axonal injury, but in most cases of pure diffuse axonal injury, you will have a normal appearing CAT scan, yet someone may be comatose. Diffuse or traumatic axonal injury accounts for impaired consciousness. Usually when someone loses consciousness immediately after TBI, it's usually because of this. It's a significant cause of impaired cognition, balance. We think it's probably related to fatigue and irritability and behavioral problems after TBI. And as I said before, standard neuroimaging is usually unremarkable. Dr. Levin, who will probably be talking tomorrow, will be giving I'm sure an excellent lecture because I've heard him speak on some of the newer techniques that are available through MRI to detect diffuse axonal injury, and we're getting better at doing that. So more to follow in lectures yet to come. Now, another way in which the brain is injured is through either hypoxemia or ischemia, and this leads to diffuse injury throughout the brain. And you can imagine that the brain, which of course is encased in there we go, in the skull, as it swells, pressure rises, and as that pressure rises, it becomes harder and harder for blood flow to get into the brain, leading to further damage. This is the secondary injury that I was talking about before, and this is the primary thing that the trauma surgeons, the emergency room physicians, the early treating team needs to prevent that secondary injury because it's deadly. And in fact, managing intracranial pressure is one of the most crucial things that the trauma team can do in cases of severe traumatic brain injury. They need to keep what's called cerebral perfusion pressure, or CPP, at a certain level so the brain is perfused. And they do that by lowering ICP to the degree that they can and maintaining mean arterial pressure to make sure the brain gets perfused. If it doesn't get perfused, bad things happen. The goal is actually to keep that cerebral perfusion pressure at 60 millimeters of mercury. That number used to be 70, actually, but as it turned out, to keep it at 70, the mean arterial pressure in many cases had to be elevated so high that we were saving the brain but killing the heart and the kidneys. And, you know, the brain may be my favorite organ, but gosh, the heart and the kidneys are also important too. As it turns out, we've known for decades that individuals after severe traumatic brain injury who even had a transient episode of systolic blood pressure less than 90 were much more likely to either die or wind up in the vegetative state. So we know just how important maintaining cerebral perfusion pressure is, and we've known that for really for decades now. It's very important, and actually one of my many hats is that I'm on the medical advisory board for the Brain Trauma Foundation, and one of their big pushes is to make sure that after severe traumatic brain injury, ICP is monitored actually very aggressively. I've had the privilege of lecturing with Jam Gajar, who's the president of the Brain Trauma Foundation, and I love it when he goes into ICUs and he talks to the trauma surgeons and what have you, and he says, "No, how do you know what the ICP is?" Well, we or how do you know it's elevated? Well, we wait for for clinical signs, i.e., clinical signs of herniation, and he says, at that point, it's too late. So it's very important, and I believe this to be true, that monitoring of intracranial pressure occur in folks who have severe traumatic brain injury because you don't want them to herniate. You want to intervene and treat the elevated ICP early on to prevent that from happening. Of course, we do that through the evacuation of mass lesions like large epidural or subdural hemorrhages. We drain CSF. There's osmotic diuresis and so forth and so on. in the Middle Ages, when I was in medical school, hyperventilation used to be the primary thing we used to do to bring down ICP. As it turns out, hyperventilation by blowing off CO2 does in fact decrease ICP, but it does so at the expense of supplying blood to the brain. So we don't often do that as we're emergently wheeling somebody to the OR for an evacuation of a large intracranial mass. Then we may do that as a temporary measure, but not as a primary measure. Another way in which the brain is injured is through this massive release of excitatory amino acids, glutamate in particular, and this causes a cascade of events that you'll hear about later that ultimately leads to the production of oxygen radicals that breaks down the cell membrane, again causing very widespread damage to the brain. And we talked about apoptosis before, that calcium entering into the cell, into the mitochondria, setting off a cascade that leads to programmed cell death. Alrighty. Again, you'll get much more on pathophysiology a little bit later this morning. Some assessments that we use, I'm sure most of you are familiar with the Glasgow Coma Score or Glasgow Coma Scale. It's a way of assessing severity of injury at the time someone sustains a TBI. We're basically assessing someone's motor, verbal, and eye ability, and you add up those scores and you get anything from 3 to 15, and we can divide injury severity on that basis. The value of GCS are several-fold. First of all, it's very reliable, it's valid, it offers a prognosis for immediate survival. That is, someone with a very low GCS is much more likely to die of their injuries as opposed to someone with a very high GCS of 13 to 15. And it's very valuable in the early management of folks with traumatic brain injury. What it's not so terribly helpful for is long-term prognosis. So it's actually often amazing to me that I'll have somebody with a mild injury who comes to my office who had a GCS of 13 to 15, yet they're so impaired they can't go back to doing what they were doing before. So mild here refers to not likely to die, not necessarily mild impact on their lives. And yet I'll have some folks who have had a very severe injury, a Glasgow of 3, 4, or 5, and somehow go on to do very well. So from a point of view of long-term prognosis, not particularly helpful. It offers some prognosis, but not much. It can also, the initial GCS can actually be very misleading. Now, I swear this never happened to me when I was in college, but some of my college friends who maybe imbibed a little too much alcohol one night, who passed out, would probably score a GCS of 3 because they would not wake up, they would not open their eyes, they would not move even though you're rubbing their sternum. So the GCS can be misleading in folks who are either intoxicated with alcohol or potentially drugs. And as I said, it just has limited utility for long-term prognosis. What is a particularly better way of assessing prognosis is by post-traumatic amnesia. And for those of you not familiar with this, it's best described as the length of time someone doesn't have recollection of ongoing events. It's measured by some fairly simple psychometric tests like the Galveston Orientation and Amnestic Test, and these are all available on the web for those who are really interested. But by and large, the longer someone does not have recollection of events, and this is both a combination of retrograde and anterograde amnesia, the worse your injury and the worse your prognosis for being able to function independently in the community. And this is probably the best tool that we have. A lot of other prognostic indicators. We mentioned GCS already. We also mentioned age, traumatic subarachnoid hemorrhage, also a bad prognostic sign. Pupillary abnormalities at the time of injury, suggesting brainstem involvement, also a bad sign. And of course, we talked about hypoxemia and hypotension. Now, hypoxemia, the brain, although it's only 5% the weight of the body, utilizes anywhere between 20 and 25% of all the oxygen that we consume. So it's very, very sensitive to hypoxemia. But even if you look at all of those prognostic indicators, as it turns out, we still can't explain all the variance in outcome. Why are these mild folks doing so badly and some of these more severely injured folks doing so good? There's likely a genetic component. We've heard a whole lot about ApoE4. This is the genetic allele that's associated with familial Alzheimer's disease, and there's some evidence to suggest in severe traumatic brain injury at least that this may have an adverse impact on outcomes. But when we look at genetics and traumatic brain injury, and I'm not going to spend too much time on this, I think it's important to realize that when genes are involved in almost any disease, except if it's an autosomal dominant condition, that the effect genes have is really, it's multiple genes. It's not just one. And certainly that's true of traumatic brain injury. And someone's genetic or phenotypic expression may depend on their race, may depend on their environment. It may depend on the specific type of pathology that we see in the brain, whether genes are going to impact it or not. I think it's also important when you look at some of the genetic studies that are coming out is that they're really hard to do well. There are many genes that are in linkage disequilibrium. That means that two genes are located on the same chromosome and are usually inherited as a pair. So you may inadvertently assign a good prognostic or a bad prognostic allocation to a particular gene when it really is the gene that it's in linkage disequilibrium with. And many of these studies that have been reported really do need to be validated, and we need a large sample size. So I would just caution you to look at these studies with rather critically. But as I said, there are many potential genes that have been identified that may impact recovery after traumatic brain injury. We just have a few up here in the work group this afternoon. For those of you who will be coming to the one I'll be giving, we'll be mentioning a little bit something about the D2 receptor gene and catechol methyltransferase gene, which may impact how somebody may respond to pharmacology. But all of these may impact recovery after traumatic brain injury. So it's still in its infancy, but I think we'll be seeing more of this. We also assess outcomes, looking at the Glasgow Outcome Scale. This is a very broad measure of outcome. It's divided into five rather distinct categories from death to good outcome. It's a very simple tool to use, unfortunately not very sensitive to change. So many of the studies, particularly a lot of the acute studies reported on probably more than 10 years or so ago, looked at GOS as a main outcome measure. And it's really very hard to move from level to level. A lot has to change before you go from severe disability up to moderately disabled and what have you. Because of that criticism, the GOS has been expanded to now the GOS Extended, which subdivides those three top categories into two different levels, and it's performed by doing a structured interview. And this is a little bit better, but it's still hard to move from level to level. What a lot of folks do in the United States is to assess function or disability by the DRS, or the Disability Rating Scale. This is something that's used by the Traumatic Brain Injury Model Systems of Care. This is a group of 17 rehabilitation hospitals throughout the country doing research, and they look at all of these different aspects of functioning to determine the DRS. This is a 30-point scale, so it's much easier to move from point to point along this scale, so it's a little bit more sensitive to change. Many of my colleagues also use the Ranchos Los Amigos levels of cognitive functioning. This is not a scale or a measure. It's really a broad description of how folks are doing after traumatic brain injury with regards to behavior and cognition. It used to be 8, but just to make my life complicated, they increased it to 10 different levels, from no response up to purposeful, appropriate, and modified independence. I don't use this particular tool very often. Individuals oftentimes at any period of their recovery can actually manifest many of these different levels. So, there are times where my patients may be confused and they're acting appropriately, and then out of no place they get very agitated. So, folks at any one particular time or during the course of the day can actually manifest many of these different levels. So I don't find it particularly useful, but that's just me. So for those of you in the audience who use it, I apologize. Alrighty, I want to spend the rest of the time talking about some of the TBI-related complications that certainly I deal with as a physiatrist, which has been the predominant work that I've been doing for the past 2 decades. And if you leave with anything today, I think it's going to be important to remember the saying, which is, you see what you look for and you look for what you know. This is so true in every aspect of medicine. If you don't know to look for a problem, you are very likely to miss it. And this is particularly true in traumatic brain injury, when so much of what we're dealing with requires a very careful assessment of the entire individual and knowing what the problems are that are associated with traumatic brain injury. So you see what you look for, and you look for what you know. Now, what sets people with traumatic brain injury apart from everybody else we see in rehabilitation is that these folks come to us with cognitive and behavioral problems. And I often say to myself, I'm going to work today because I may get slapped in the face by my patient. What could be better? I say that jokingly, but in fact it's happened. But this is really what separates everybody else and what makes our work challenging and actually in many ways surprisingly rewarding. I'm going to talk a little bit about some of the behavioral disorders we see, depression, apathy, and my favorite, agitation. Briefly go through these, although I'll be talking about them more this afternoon in the workshop. So depression. Depression is something that's actually very common after traumatic brain injury. Some estimates show it to occur in more than half of folks with traumatic brain injury at some point after their injury. So it's very, very common. Acutely, when folks are in the hospital after traumatic brain injury, it's oftentimes difficult for the physicians to sort of pick up on this. You know, I like to think of myself as a caring physician, but you know, when you're making bedside rounds, you're with a patient 5 or 10 minutes, and oftentimes folks are trying to put their best face forward for the doctor. So I often listen to what my patients my patient's family are saying, what the nurses are saying, what the therapy staff is saying. It's so important to gather that information because the physicians may not pick up on it themselves. And I will say that particularly in the acute setting, you know, when folks are in inpatient rehab, and in the United States we have such little time for acute inpatient rehab. It's not like the old days when folks stayed 6, 7 months. Now they're staying 2, 3 weeks. That we really need to treat the depression fairly early. I like to avoid the tricyclic antidepressants. There are many, many drugs around now that are much better than them, that have fewer side effects. But we do use quite a bit of the serotonin reuptake inhibitors, and there's a whole host that you can choose from. Most folks like to use something fairly simple that's safe, like sertraline, but oftentimes we'll wind up giving a stimulant to that, particularly early on when they're in the acute inpatient setting, because we need them to participate in rehab aggressively since we have such little time. So oftentimes I'll combine something like sertraline with methylphenidate just to get that effect going quickly. Some folks will use dextroamphetamine or modafinil for the same purpose, although modafinil as a drug has not been very well studied in traumatic brain injury. Now, one of the things you have to consider when you're dealing with sort of mood disorders and traumatic brain injuries is to make an assessment of whether you think your patient is depressed or just apathetic. So is my dog here upset because I yelled at her for doing something she shouldn't, or is she just apathetic and doesn't want to play with her red ball? Not always an easy distinction to make, but you know, we can see folks who, just as a primary difficulty with their traumatic brain injury, they're just profoundly apathetic or have this profound lack of initiation. Certainly you need to make sure they're not depressed, and again, we talk to family members and to staff, but you want to make sure that it's not an issue of initiation, because if it is, or they have something, or they're like in the akinetic mute state, oftentimes what we'd like to use is a dopaminergic agonist like bromocriptine or amantadine to try to improve that, and there's some evidence that that may help. With regards to depression, though, and affective disorders, recent guidelines that have looked at the literature have shown that both tricyclic antidepressants and the serotonin reuptake inhibitors are effective in treating depression after TBI. But as I said, we really like to avoid the tricyclics. Potential effects include, you know, seizures, mania, the impaired balance, particularly in the elderly. So I would say that most people stay away from the tricyclics and just go for the serotonin reuptake inhibitors, despite that there is evidence of their effectiveness, the TCAs, with regards to depression. You're going to be getting an awful lot on cognitive remediation, so I'm not going to spend a whole lot of time on this with you here today because there are going to be folks here in the audience who are giants in the field, so I'm not going to pretend to know what they know. But I would say that pretty much the state of the art in the United States with regards to treating cognitive impairments is through the process of remediation. And this is a process where we utilize relatively well-preserved cognitive skills to help folks develop compensatory strategies for identified areas of cognitive weaknesses. And we do this in a number of different ways. Cognitive exercises, the use of memory books for folks who have memory problems, alarms to remind them when to take their medications, electronic organizers if they can. They're probably better at doing it than I can. I still can't use my BlackBerry properly, but be that as it may. Boundary markers, just putting a large or a colored rope onto a table and putting only what the person needs to attend to, so help to potentially compensate for distractibility and what have you. Providing structure to somebody's day so they're doing the same thing at the same time day after day, because folks with traumatic brain injury may not be able to deal with too much flexibility. Making sure that their sleeping patterns are okay, because if folks are tired, like I am now, a little jet lagged, it becomes a little bit harder to go about your day. You may be hearing a little bit more about this, but these techniques are effective. Keith Cicerone and his colleagues have published extensive reviews of the literature, both in 2000 and 2005, and they're actually working on yet another supplement to this to determine, by looking at the literature, how effective cognitive remediation techniques have been. And in fact, they are effective in improving attention or addressing issues of impaired attention and apraxia and what have you. Comprehensive holistic rehabilitation, which I'm sure you'll hear about, and we have the father of comprehensive holistic rehabilitation in the audience, Dr. Ben Yashay. These are effective in helping folks deal with their impairments. And we'll hear a little bit more about that. From a physician perspective, I think it's important to know that we have to be very careful with the drugs that we provide our patients. There are a number of drugs that can impair cognition. And when you're dealing with folks who are already tired, who already have impaired cognition, the last thing that we want to do as physicians is to give them something that's going to make them worse. So we try to avoid the older neuroleptics, the Haldols, the Mellarils, the Thorazines, and what have you. We try to avoid benzodiazepines because we know that this can impair cognition and they're addictive. Sedating anticonvulsants. It's I think one of the reasons why I'm somewhat well known in New York City for treating folks with traumatic brain injury is that I would often get folks who had a severe traumatic brain injury but never had seizures, that they'd come to rehab on high doses of phenobarbital, and they would almost be minimally conscious or even look vegetative. I would take them off of phenobarbital, they would wake up, and I got the reputation of curing coma. So for all of my colleagues in New York who like to use phenobarbital, thank you for making me famous, but stop using it. I've reached my pinnacle. Oftentimes you can stop some medications. And I think the most important thing that I like to get across to an audience that I lecture to with regards to pharmacological treatment of TBI, the first step is to minimize. We also like to make sure that we avoid excessive stimulation or cognitive demands. Certainly we want to challenge our patients to get better, but not so much so that we turn them off or get them agitated. There are many drugs that we think enhance cognitive functioning. This is a lecture unto itself, and it will be a focus of my workshop later on, so we'll discuss a little bit more of that later on. I do want to spend some time, though, on the management of post-traumatic seizures. A fairly common problem with severe traumatic brain injury affects about 15% of folks with severe TBI. We divide them into two broad categories. Early seizures are those that occur within 1 week of trauma, and there are a number of risk factors that may make you more likely to have an early seizure: intracranial hemorrhage, penetrating trauma, as you can well imagine, or a depressed skull fracture that's associated with a specific neurological impairment. And what I'm interested in as a physiatrist, which are late post-traumatic seizures, and those that are seizures that occur more than 1 week after the trauma. And the issue is, what do we do with regards to the prevention of late post-traumatic seizures? And I'm going to go into this a little bit more later on in the workshop, but by and large, it's actually quite simple. There's enough good level 1 double-blinded placebo-controlled trials to say that as a standard of care, if an individual has not had a seizure, there is no need to provide prophylaxis for long-term or for late post-traumatic epilepsy. The data is very clear. Classic article by Nancy Temkin in the New England Journal back in the early 1990s, showing that as a group, dilantin or phenytoin was ineffective in preventing post-traumatic seizures or late post-traumatic seizures, and in fact, although it didn't reach statistical significance as a group, the folks who got phenytoin had more seizures than those who were not receiving it. And there are other studies that basically back that up. So now that may not be true for any one individual, but as a group, that was certainly shown over and over again. It was felt to be an option to provide early prophylaxis for seizures because, as it turns out, phenytoin and others are effective early on, and we think it's good to prevent seizures early on because, the brain is metabolically challenged, and we certainly don't want the brain that's metabolically challenged to have to use up whatever oxygen and glucose, whatever, to feed a seizure. But the truth of the matter is there's no evidence that shows that preventing seizures during that first week has any impact on long-term outcome. It may, but the evidence is not there, which is why it's an option and not a guideline or a standard of care. Other medical problems that we deal with that I deal with as a physiatrist, and we'll go into this in the workshops, hydrocephalus, very common. I suspect this occurs in my patients when they're simply not progressing as I suspect they should, or they're progressing and they stop, or there's a slight decline. Electrolyte imbalances, actually more common. I always like to say that hyponatremia, not exactly an exciting topic, but is not always due to the syndrome of inappropriate ADH secretion, but may be due to something like cerebral salt wasting, which I'll talk about this afternoon. And the treatment of those two problems are vastly different, and you have to be careful in making sure that you manage that properly. Heterotopic ossification, this is basically bone growing where bone doesn't belong. Affects the shoulders, the elbows, the hips, to some degrees the knees following traumatic brain injury, and can really cause severe impairments in mobility and ADL function. The management of this is somewhat controversial. I believe that early surgical resection is probably indicated in many folks. Others would say that the early resection results in increased likelihood of the bone growing back, so a bit controversial. I'll be discussing this afternoon. Pituitary dysfunction, again, this goes under the category of you see what you look for what you know. There is very good data coming out that pituitary dysfunction after traumatic brain injury decreases in growth hormone, thyroid hormone, sex hormones, all significantly impaired in many folks with traumatic brain injury, and that may, in fact, be causing many of the problems that we see with regards to fatigue and changes in body habitus and what have you. So pituitary dysfunction is going to be big in the future. Again, we'll be discussing that this afternoon, as well as some of the other motor problems, spasticity in particular, and how we treat that in the rehabilitation setting. I just want to end up talking a little bit about mild traumatic brain injury. I know I touched base on this earlier in the lecture, but mild traumatic brain injury is really a big problem. Most of the TBIs that are sustained are, in fact, quote, mild. And when we say mild, again, we're just referring to the fact that these folks are not likely to die as a result of their injury, not because the effect on their lives are mild. There are many, many different definitions of mild traumatic brain injury: concussion, minimal brain injury, mild brain injury. I've heard it referred to as compensation neurosis, as though everybody who has a concussion is out for money. In any event, the American Academy of Neurology has a definition of concussion, as you can see here, grades 1, 2, and 3. And I even bring this up because it points to the fact that in order to have sustained a traumatic brain injury, it does not mean that you have to lose consciousness. I think that that's a that's a definite misunderstanding that many people have. Most concussions occur when there's no loss of consciousness, but there is some alteration of mental state or mental abilities. And the American Academy of Neurology has divided this into 3 different grades, grades 1 and 2, in which there is no loss of consciousness, but there is some alteration in mental state, and the only difference between grade 1 and grade 2 is how long those symptoms last. Anybody with loss of consciousness is already determined to have a grade 3 concussion. Many years ago, the American Congress of Rehabilitation Medicine came up with their own definition of mild traumatic brain injury, which we have here defined on the slide as a traumatically induced alteration in brain function or mental state, which is manifested by any one of these 4 things, either loss of consciousness, although loss of consciousness cannot last more than 30 minutes, memory loss for either before or after the accident, or any alteration in mental state, and this can be a sense of being dazed or confused, or any neurological finding. However, the severity of the injury can exceed either loss of consciousness lasting 30 minutes, the GCS being less than 13 after 30 minutes, and post-traumatic amnesia cannot last more than 24 hours. And this is the definition that many have used for the past couple of decades. This just shows what the definition excludes, which is sort of common sense. The Center for Disease Control earlier this decade, in their report to Congress, came up with their own definition of mild traumatic brain injury, which in many ways is similar to the American Congress, but worth reviewing here as well. This is any injury to the head as a result of blunt trauma or acceleration, deacceleration injury, as we discussed earlier today, in which any one of the following can be observed or self-reported: transient confusion, disorientation, or impaired consciousness. Any dysfunction of memory around the time of the injury, again, very similar to the American Congress definition, and loss of consciousness, or I should say loss of consciousness that is less than 30 minutes. You can also diagnose it by having observed signs of any type of neurological or neuropsychological dysfunction, and may include things like a seizure after the injury. Among infants or the very young children, irritability, lethargy, or vomiting after the injury. And in older adults, in older children and adults, things that are supportive, although not diagnostic according to the CDC, may be things like headache, dizziness, irritability, fatigue, or poor concentration. However, in the absence of either loss of consciousness or altered mental state, that only supports the diagnosis and does not make the diagnosis. So with that, didn't go quite the hour and 15 minutes, but I think it makes up for a little bit of lost time. I'm very happy to take some questions, and hopefully I'll be seeing some of you this afternoon as well.
I thank you very much, Professor Flanagan, for your excellent lecture. And I think, Kristalena, we have not time for questions. Time of questions will be at the workshops. We are in delay, so you can continue.